Good Gabs, sponsored by Skillskin, a nonprofit organization empowering individuals with disabilities through employment. Wow, it's another week. We are closing in on a year right now. I cannot believe it. And as always, we are bringing the fire today. Today, it's an exciting conversation. We have the great pleasure to have Jeff Thomas, the CEO of Frontier Behavioral Health, with us today. Good Gabbers, I know you're looking forward to this one. Jeff, thanks for joining us today.
Yeah, thanks for having me. Looking forward to it.
I know it's kind of a balmy day, and this area needs some water. I'm looking forward to it.
That's the optimistic attitude we want on a rainy, cloudy, stormy day. So yeah.
I never was that way until I ended up working for a water district on the board of directors for a West Plains water district, and now every time it rains, I know it's going down, and we will have water come August.
Yeah, that's a good thing.
Heck yeah! Well, how's your day going?
Going well. Yeah.
Excellent.
Yeah, winding it down or trying to. So.
All right. Well, thanks for joining us today again. And I know our listeners, Frontier Behavioral Health, we all know the name, but I don't know if we all know the organization. So maybe help us understand a little bit about what's going on there.
Yeah. Well, just maybe a little bit of history to just start.
We'd love that. That sounds great.
So we're about a month away from turning 12 years old, but that's a bit of a misnomer because Frontier was formed out of a merger 12 years ago of two longstanding organizations who between them had about 150 years of experience in our community. Yeah. So Spokane Mental Health and Family Service Spokane made the decision strategically to merge, and that occurred on July 1st of 2011. So, yeah, and so we're one of the largest, if not the largest, community behavioral health agencies in the state.
Really?
Yeah.
All right.
So and that's got some good things and some challenges, right?
I can imagine.
But yeah, we've got about 850 positions in our organization, 18 different locations, and we're closing in about $100 million annual budget. So we've more than doubled in size since the merger, and serve over 20,000 individuals in their families each year. So,
I read that this morning, over 20,000. That is shocking. That's a lot of people served.
It is, and it's not all the need that's out there either. I can tell you that.
Well, I'm curious about just your opinion on that. Are we, as a community, able to cover a majority of the need, or let's just start there.
Yeah, I would say that's an overstatement. I think the needs. It's hard to know exactly to measure exactly how great the need is because we don't know what we don't know. But just when we look at the requests for services, the demand that we see, we just know that we're not able to accommodate all of that. And some of that has to do with just the general structures that are in place. Some of it has to do with something that's just at the forefront of our minds daily, and it has been for the last several years, which is a tremendous workforce shortage.
Right.
And
I read you changed your model of how to help people just recently. How's that going?
Yeah, it's going well. It's not without its challenges, but one of the things that we're keenly aware of is that the behavioral health workforce shortage crisis, and we don't use that word lightly, isn't something that's going to abate anytime quickly.
Right.
We're not going to wake up, in next year and say, "Oh, good, it's over." We have a flood of providers coming in. Now we can meet all the needs. So it's incumbent on us as providers to be creative, adaptive, and figure out different ways of providing services, different models, different ways of utilizing our staff to top of credentialed or staff who aren't credentialed. And so, we really retooled our outpatient services about a year ago, and it's going well. It's a team-based model utilizing a lot more bachelor's trained clinicians. We've developed an entire...
Awesome.
Yeah, but rare is the person who comes out of a graduate program, much less an undergraduate program, with their diploma and they know how to do the type of work we're doing.
Right, yeah. So having some experience under your belt, I'm sure that helps them if they want to go after some additional credentials, right?
Oh, no, absolutely. And we've developed a clinical training academy. We actually have a clinical learning center, and our new employees come in and they get more than 100 hours of training. So it's almost like a mini master's degree over a several month period to really help prepare them to be doing the nature of the work that we're involved in. So it's been exciting. There's been a lot of learning that we've done through the course of it and mistakes made. And then you kind of adjust and adapt and move from there. But it's been exciting.
Well, happy to hear that. And that's great for Spokane, too. And you can kind of just pivot, change, adapt. I know we're doing that in our own work at Skillskin right now. It's like we're having a really hard time finding people with disabilities who want to, engage in the workforce. And that's just never been a thing for us. Like we always had people who wanted to work. And so we employ a lot of people, but we also help people find jobs out in the community as well. But right now it's just, we're having to adapt and finding other partnerships in Spokane. We're working with Catholic Charities, trying to work in the low-income housing world. We started talking to your organization too, actually.
I know.
Yeah.
I was just going to say, when I was walking out the door and talking to our service directors, I said I was coming over to do this, and she said, with whom? And I mentioned Skillskin. She said, oh, yeah. We're working with them now and trying to, kind of help meet some of our clients' needs. So, yeah.
It's awesome. Well, and that kind of ecosystem that, that we're building is I guess a community I'm just excited about. I think we can really help people.
Yeah, those partnerships are key. I mean, and that's one of the things we talk about in our organization a lot is, we provide a vast array of services. We have 50 some odd different contracts and we're providing, all kinds of inpatient, outpatient crisis services, but, there's no way that what we're doing can provide the type of services that meet people's needs on our own. So everything's built upon partnerships and contingent on partnerships. And whether it's with law enforcement, medical providers, whether it's with schools or other not-for-profit organizations, I mean, it is that kind of fabric within the community that is necessary and critical to make it work.
Well, that sounds incredible. That sounds like how you can move mountains and really impact and change communities for the better.
Yeah, and sometimes the mountains don't feel like they're being moved; they feel like they're being slowly climbed, right?
Right.
But that's the nature of the
movement, though.
Yeah, absolutely.
Well, I'm thinking about our listeners. Like I said, a lot of us we know the name, we don't know exactly what the organization does. But 50 plus lines of service. What's something that you might highlight for us today that we probably just don't know that Frontier Behavioral Health does?
Boy, as I go through my mind thinking of the 50 different contracts or so, I guess maybe one that I'll highlight is something called Wraparound Intensive Services for Youth. So that's a program where we're serving about close to 200 youth and families each month, and the office space that's occupied by the team of 45 or so staff, clients they never come in there. All the services are out in the community, in people's homes, wherever it is, in parks, in libraries, in settings that are their preference and that meet their needs at the hours and time that they need. And
custom service.
Yes, it is. And it's a multidisciplinary team. We have clinical master's level clinicians. We have bachelor's trained clinicians. We have what are called adult peers or parent peers and youth peers. So a parent peer is somebody who had a youth who at one point was struggling with mental health issues. And a youth peer isn't a child that we're employing illegally. It's somebody who is an adult who, as a youth, went through mental health issues and challenges. So those people can really kind of help, walk alongside of the clients and really help them to kind of guide them and partly just help give them some hope. So, and we also have prescriber services.
Yeah, they can see themselves, right? Yeah. As an adult, they're like, oh, I can make it through this challenge.
Oh, yeah, which is huge.
Powerful.
It's huge. And then we have medical providers as a part of it, too. And so it's really a team approach that's neat. It's serving a lot of folks who many times these youngsters would be, they're the ones who are not making it in school, not making it in traditional settings, at high risk of being in institutional care, but helping to keep them in their homes and their communities. Yeah, it's a pretty neat program we've been doing for a number of years now.
And so what age of youth is this program helping?
Really it extends, down pretty much into, grade school youngsters. And it can be, there's no particular limit, but, 5, 6, 7-year-olds can be in there, but all the way up through, 18-year-olds. And so it's really a broad array. I think we see a lot in the 10, 12, 15 age range.
That's incredible. I definitely didn't know about that, and I don't know. We've had a lot of people in this your chair right now that are service providers in our community and folks who deal with youth in lots of different ways, and we've learned a lot. Like early childhood development. Some of the things, if we interact with people early, we can help set them up as an adult. Is it the same in mental health when we connect with people early?
Yeah, it is. And I think, one of the challenges that there's the funding oftentimes is for good reason, kind of following where the most acute needs are. And those acute needs oftentimes are not identified until somebody's in kind of real trouble.
Like crisis.
Right, crisis. Yeah. So inpatient care, crisis services. So, we're continually looking at how can we find ways to intervene earlier and help to minimize the trauma that individuals experience, because those end up really kind of cascading forward and increasing the risk of individuals as they move into adulthood, having significant challenges, whether it's mental health issues, whether it's substance use, difficulties with employment, socialization, all those things. So yeah, anything we can be doing to intervene earlier is a good thing. And again, that's one of those ones that's not done alone. It's done in partnership with others. And one example of that too, I'll share that folks may not have known about, but we have really strong partnerships with a couple of not small school districts locally. One is East Valley, and we've been in East Valley School District for almost 20 years now. Oh wow! Yeah, and it's we call it our FAST program, Families and Schools Succeeding Together. So we have mental health clinicians in each of their schools between 1 to 3 or 4 or 5 days a week, providing services on site, and it's just been something really fantastic to kind of help support their students. And we 3 or 4 years ago entered into a similar contract and arrangement with Central Valley School District. And when I say contract, the districts are, we're fortunate they provide a certain amount of funding to support that. United Way.
They're prioritizing this.
They are, which is good. Yeah. United Way of Spokane County has been a fabulous partner in supporting some of that. And then through our just regular Medicaid funding, we're able to patch this together. But it's an example of earlier intervention that wouldn't be occurring otherwise for those students, those young people.
Incredible. Yeah, just layering all those funding streams together and just someone saying, yeah, this is a need, let's fill the need, we'll figure it out.
Yeah, and it's the kind of thing that folks have asked, well, gee, why aren't you doing that with more school districts? And part of the answer is just bandwidth, but part of the answer is that these partnerships, kind of like marriages, they don't just, you don't just fall into them and they sort of work because they logically might work. They take just a lot of time, energy, commitment, intentionality, willingness to make mistakes and forgive each other and figure it out. And that's not easy.
No.
So, not easy whatsoever. So it's really, I think the fact that it's working with those two districts is a testament to their commitment to figuring it out with us. So it's a cool thing.
Well, here. Clap for East Valley and Central Valley.
Yeah.
Thank you.
Yeah.
Those kids are lucky.
Yeah.
Well, how long have you been in this world? Like, are you a clinician?
Yeah, by trade, I'm a licensed clinical social worker and a licensed marriage and family therapist. And so, yeah, I've been in the field, for getting close to 40 years. Yeah, which sounds
That's a minute.
Yeah. So, but, I actually accidentally kind of came into this field. My undergraduate major at Whitworth University, or Whitworth College at the time, was journalism. And I was doing an internship at the Lewiston Morning Tribune.
All right.
Between my junior and senior year, and went down there and I learned two things I tell folks through that experience. The first was that I didn't want to be a journalist. And it's like, well, okay, that's not
good.
Not what I expected to learn, but it's not a bad time to learn something like that or figure it out, as opposed to a few years into a career or 10 years in, right? And the second thing I learned was, I had the opportunity to be doing some feature stories, interviewing a few individuals doing, it wasn't mental health work necessarily, but it was social services.
Sure.
And so I thought, gosh, I want to be doing that stuff, not writing about it. So how do I go about that? What's the path? So when I came back to school that fall, I beelined it to my sociology prof. I said, how can I pursue something like this? And I didn't know anything about the field at all. So
You just had the feeling. You're like, I want to
yeah.
be a part of this.
Yeah, this seems like this is kind of it really felt like a calling to me. I mean, truthfully. And so he suggested I get a master's in social work. So that's what I did, and that kind of, charted the course for me. And then through a number of, job changes and moves, and I got a doctoral degree in administration at the University of Pacific down in Stockton. So we moved around a bit, and yeah, it's from there. It's
So your career took you out of Spokane then for a while.
well, yeah, and my wife's career took us
Yeah.
out of Spokane. We moved down to Sacramento area for a number of years, and worked in that area, and that's where I received my doctorate, and also worked in the Davis community, and then we actually lived in New York City for a bit.
Oh, wow.
Yeah, she was moved up the corporate ladder, and I accepted a job at a homeless shelter in Upper East Side of New York City, and then I actually, when I gave notice to my employer in Davis, we had a very entrepreneurial CEO at the time, and she said, well, how about instead of quitting, we just, you don't have any kids, you seem like your wife's going to be traveling a lot. She was going to be a national sales training person for her company. And, how about we just fly you back and forth, and you keep working for us?
Wow.
And so I did that for like 2 years.
Incredible.
Yeah. So
You had all the airline miles.
by the time I was done, I had like 16 trips racked up.
That's awesome.
And I knew all the tricks about how to sleep on a red-eye flight, and how to, the minute that you're able to get up to go and find where there's 3 seats for a 6'4" guy could lay down and try and sleep for the
I
night.
love that. Yeah.
So it took us there, and then we moved back to Spokane in 1992, and we've been here ever since. And I took the job as CEO of Family Service Spokane, one of the 2 organizations that subsequently merged, in 1997. So nearly 26 years ago. So I've been a CEO of, around 13 years in one organization and 12 plus in the other since we merged.
So you were part of that conversation of merge then.
Yeah.
And well, I'm curious, we've had a lot of people also on the podcast who talk about, there's a ton of nonprofits in Spokane, a lot of people kind of overlapping services. And is there a way to do some combinations to just impact the community better? Like, I imagine these are the conversations you were having back then. Could you walk us through that? That's really curious.
Yeah, because mergers can be a very challenging thing. And it's not uncommon for them to be painful. And it's also not uncommon for them to be essentially an acquisition.
Right.
Right. And somebody then subserviates their identity and everything. And it's like, okay, and it's also not uncommon that they're born out of one organization being in a position where they feel like they're not going to survive. So it's okay. It's like, as a survival strategy, we will merge and be acquired, and not our favorite thing, but here we go. And that wasn't the case, which is very positive and favorable to the circumstance that we had. It was really a product of our organizations had worked very closely together for many years, and the impetus was the passage of the Affordable Care Act.
Okay, yeah.
And when that occurred, we thought, things are going to change. We don't know how they're going to change or what way, but we have a pretty strong feeling it's going to implicate our world in behavioral health. And the nature of the work that we're doing that's separate from each other but interreliant in different ways based on our programs, we feel like we'd be stronger and a better resource for the community and better able to kind of leverage and maximize what we're able to accomplish if we become one larger organization. And so then we embarked on that process. And of course that takes, boards of directors who are willing and able to take that step.
Yeah, big risk, big vision.
Yeah. And so kudos to our boards of directors at the time and into our executive leadership teams to really kind of help make that happen, to, go through the due diligence process, say, okay, you start with, and actually our conversation didn't start with, hey, how about we merge? It started with, how do we develop more of a close-knit partnership? And what would that look like? And went through a number of iterations of how that might look. And then it's like, it then evolved into, why don't we just merge? Okay, let's not just date and go steady, let's merge. But it didn't, but it was iterative, which is kind of, I think, also a positive because it wasn't just sort of, hijacking things, right?
Yeah.
And so our
I
board,
love the iterative process.
we really learned from those conversations. And then our boards went through a due diligence process. executive leadership teams did, and then we made the decision that it would be, the best thing to do, and we all felt really good about it. And then, we moved into that, and then of course, you have a lot of staff in both organizations who are, wondering, well, what's this mean? But there's no loss of jobs, and based on the size and scope and nature of what we did, it's not like we had, more people than we had positions. Like we didn't need to, lay anybody off. We didn't have two CFOs, and one's going to have to go. And it turned out the CEO, and I wouldn't say it turned out. It was the case, and it was a part of the planning and the process that the CEO of the other organization was about a year out from retirement. So
it was good timing, too.
Yeah, so it was really kind of a nice flow. That didn't drive the process, but it certainly informed the conversations, and it made it just much more natural and fluid, for that to kind of evolve the way it did. And yeah, no regrets about it. In fact, just the opposite. I think it served us extremely well in terms of what we're able to accomplish. And it was neat too that we found ways in which the culture and textures and priorities of each organization, those found their way into what became the Frontier Behavioral Health way of doing things. So it wasn't just one way. It had to carry the day in all instances. So yeah,
taking the best of both worlds.
Yeah,
I'm sure you can still see that today in the organization, some of where the beginnings were.
Oh, yeah. Absolutely. I was just in a meeting at the end of the day yesterday, and we were talking about a matter related to training and supporting our staff, and we were having that very discussion about kind of how some of where we're at now came from each of the prior organizations, and it's still reflected to this day. So yeah,
that's an
cool.
Awesome story. And yeah, if you're thinking about this, listeners, I know a lot of you are running organizations yourselves. Like, this is a great example that Jeff's sharing with us of how it can work. So yeah, just thank you so much for that.
Yeah.
So yeah, there was capacity now. We could start to grow. So what's the future start to look like for Frontier?
Complicated.
We're going to layer more funding, add more programs.
Yeah, it's when I look at, one of the biggest changes in our world came in when our state made the decision in 2015-16 range, but to move toward what they called integrated managed care model. So primarily the outpatient services that we and other community behavioral health agencies provide are under Medicaid funding. So it's for Medicaid enrollees, which, by the way, there at the time we merged, there was less than 1 million individuals on Medicaid in our state. Now there's more than 2 million.
Oh, wow.
So it's like
doubled.
And
that's a short period of time.
Affordable Care Act, Medicaid expansion, a lot more individuals on Medicaid, which brings with the behavioral health care benefit. So a lot more people in need of and having access to our types of services. So, as we look at how that's informed our growth and expansion, but with the transition to integrated managed care and all that's brought with it, we went from one primary payer in 2017-18 range for our behavioral health services to now we've got, again, in one primary contract, I mentioned 50 plus contracts, with different Medicaid managed care organizations, with the Health Care Authority, with the Department of Health, some with federal grants, some with Spokane County. So it's sort of this complex labyrinth of different contracts and services.
You have to really know what lever to pull to make sure that reimbursement comes.
Yeah, and how to blend these together in ways that they complement one another. So what does the future hold? I just did a few weeks ago a nearly 2-hour presentation to our 100+ managers. And I also did a parallel presentation to our board of directors, and it was called something along the lines of the landscape of behavioral health in the state of Washington, and sort of our planning and strategizing for the next 3 years. And the very next slide is a crystal ball, and then the animation I have on it is a big cloud coming into that crystal ball. So if you think I know what's going to happen in the next 3 years, that's not accurate. And I harken back to if I had been standing here giving the same presentation 3 years and some change ago, so early 2020, would have never seen COVID coming.
Right.
Big variable. Would have never seen the workforce shortage crisis coming. would have never seen some of the significant legislation that's occurred, that's impacted our world, would have never seen something that's now a big part of our world is the 988 National Suicide Line, which is part of what we are a provider of. I mean, there's so much of what we're in the middle of now we wouldn't have seen coming. So the most accurate prediction I can make is that I can't predict what's going to happen.
Makes sense to me, but that's when you build up your leadership team, right? And the folks that can do the work to be able to iterate, evolve. Like how do you and your leadership team just tackle some of those issues?
A part of it is we do a lot of piloting of concepts, all right, and testing out, and it's within the organization and with partners we have in the organization, and literally just in the last week we've had conversations with healthcare providers, with law enforcement, with the emergency departments, looking at what are some additional ways we can test out some different ways of partnering, of responding to needs in the community. And when we enter into those partnerships, it's sort of a cousin to my crystal ball analogy earlier, which is I say, here's what I can guarantee you. There's much that I can't in this partnership we're entering into. But one thing I can guarantee you, absolutely, is we're not going to get it right the first time. We're not going to stick the landing. It's just impossible. But I can guarantee you we're going to be in it with you, and we're going to work it through, and we'll learn from it. We'll figure out. We'll be forgiving of one another, and we'll be committed to kind of seeing it through and making it happen. And I've never been wrong about the fact that I've never been wrong about the fact that, right, we make mistakes. Yeah. But I think so if I look at what the future is going to hold, it is something where there's going to be change. There can be the unpredictable. There's, how do we do everything we can to sustain the core of what we're doing and to evolve and adapt, as we're going forward. Yeah, I remember back, it was in 2016, there was a forum that Providence and I think Eastern put on here in town, and they brought in Patrick Kennedy, who's a big mental health advocate, just really fantastic voice in behalf of those struggling with substance use disorders and mental health issues. And then they had a panel on the stage afterwards that I was asked to be on. I was honored to be a part of it. And we were queued on a few of the questions that we asked, but then the moderator decided to mix things up.
Here we go.
Yeah, and so at the end he said, okay, well, what do you see as the most important ingredient or element related to addressing needs of individuals with mental health issues? And the one word answer I gave was partnerships. And it goes back to what I was talking about earlier. We can do wonderful services, and our staff do every day in the clinical setting, in that clinical hour or half hour during that conversation, but that alone isn't going to do it. So if I look forward and you're asking what does our future hold, I think it's going to be more piloting, more stepping out into the unknown and experimenting, and deeper, stronger, more involved partnerships with others.
I love that. About 2 weeks ago, we had Ben Stuckart from Slick on, and he was talking about this new regional approach that we're putting together for homelessness and pulling all these partners together. I imagine that Frontier is an integral partner in that. Is my imagination right?
Yes.
Okay,
yes,
good.
Yeah.
So how do you feel about this and like this new idea of partnership and this iteration that we're about to stand up?
I think it's a fabulous idea. And again, it's one of those things where it's impossible that it's going to be perfect. It's impossible that it's going to solve the homelessness problem, but it's also the case that were there not to be efforts like that, then that'd be a really bad thing. Okay, so if you wait for the perfect concept that is you're positive is going to solve a problem to step into it, you're just going to be sort of immobilized.
Right, the need gets greater and things change on the ground.
Right, so I think those sorts of efforts. We have a homeless outreach team that's been doing this work for 20 plus years. It's a very small team of just several staff. I mean, their day job isn't in an office. It's out under the bridges in the homeless camps. They are out engaging with individuals every day. And they know better than anybody. We have a fantastic supervisor of that program who's been doing it for 21 years. Everybody in the community knows she's an expert. Crystal Alderman's her name. I'll give her a shout out here.
All right, Crystal.
And and we've learned a lot. And I tell you what, it's complicated. When people talk about the homeless population, right away we have a misnomer. There's not a homeless population. In my morning walk today, as I was mentioning to you before we started, through the park, I saw a few dozen homeless people. Everyone has a story of their own.
Heck yeah.
Everyone has a history of their own. Everybody has some other challenges they're facing. And it's not one homogeneic population. There's many different homeless populations, many different individuals and families and stories. And so it's not just one solution. We're fortunate that we received some funding under a contract to more than double the size, almost triple the size of our homeless outreach team. And so here's something that's kind of exciting for us. We're on the front end, just hiring the staff for it. But we're being funded to provide not just the current homeless outreach services are to reach out to folks, help to connect them with services, but those individuals have to come in somewhere for the services. This is a program where we're bringing outpatient mental health care to them where they live, providing it on their own. So we have a nurse, a peer support specialist, a prescriber, mental health clinician, and guess what? We'll bring the care to you. So sort of like I mentioned with our youth, we'll provide some of the services in homes. Now, if somebody's home is under the Monroe Street Bridge, hi, here we are to provide services, and we'll come back next week. We'll have some scheduled times or unscheduled times, but you don't have to leave where you're at to come to where we're at. And, when people say, well, why would somebody not want to leave? Are they lazy or they do not care?
They might not be able to.
Might not be able to. And there's also individuals who, if they vacate where they're at, their belongings are most likely not going to be there. To try to bring those belongings onto a bus, that might not be allowed. So, it's not a small thing for these individuals, for us to have an understanding of the challenges that they face, and for us as providers to transcend the barriers to try and respond to their needs. And get outside of the traditional ways that services are provided or funded or allowed to be, delivered. I mean, that's some of that experimentation. So,
it's incredible.
Yeah, and can I predict how it'll turn out? No, but
we're gonna try.
Yeah, we're gonna try.
We're gonna fail first time.
Yeah, and what I can tell you is, if we weren't doing it, these people wouldn't be getting any services. So, so we're really excited about kind of moving forward. That is one small part of this larger picture that we're seeing.
Heck yeah, that's the spot where people can start to get unstuck, right? Maybe that's that inspirational moment. Like, okay, yeah, maybe my life can be a little different. Maybe I'm taking care of, whatever need that needs to happen at that moment.
Yeah, and you know what? It's interesting where the latitude we have with the funding for this program is so interesting. And this is going to sound either silly or revelational or just like duh. Some of the funding is like, they'll fund us to, we'll buy backpacks and we'll bring cans of dog food. Why would you, really? Clinical services, dog food? Guess what? If somebody has a dog and that dog's hungry and that's their only friend and companion in the world, and you're helping that person to support that dog, all right, now you've taken one small step toward building trust and being somebody that's useful. As opposed to you come in and say, you seem like you have a mental illness. How about we give you some meds and do some counseling? Yeah,
it sounds like real judgment, right? At first. Now you're coming in alongside someone.
Yeah, and I'm going to help you. I see a real need there. You have it. You're one companion, and they're in need, and I'm going to help you meet a basic need. Absolutely. Those are the kinds of things that really help to build trust, help to build relationships, and they become building blocks for therapeutic care and intervention.
Yeah, you can start asking some additional questions after that.
And
I see it. It's brilliant.
And that, a pair of socks, just the basics. And that can take, in fact, our homeless outreach team will tell you, sometimes it takes 2 or 3 or 5 or 20 or 30 or 40 or 50 occasions where you're interfacing with somebody. It's not like, okay, well, last week I gave you a pair of socks. The week before that I gave you dog food. Now let's get going with therapy. Not quite that easy.
Right.
Much more complicated. But again, those are the kinds of things I think, and many other examples of ways to kind of creatively address the needs in our community.
It's incredible, Jeff. Yeah. It's that empowerment model is how I'm hearing it. And when you get to come alongside somebody, you're not saving anyone. You're just giving them a choice and opportunities to better themselves or heal themselves. That's incredible.
Yeah.
Huh.
Yeah.
I wish we had more time to talk. This has been incredible.
Yeah.
Any last words for our audience today?
I would just say, as your listeners and viewers are going on their daily walk in life, there's no doubt that every single day they're encountering individuals who are struggling with mental health issues. They themselves might be, their family members, their neighbors, others that they encounter, and just to be mindful and compassionate and supportive. One of the earlier this spring, just early May, our Surgeon General of the U.S. Declared basically, he said, you know what, we have an issue in our country, and it's around isolation and loneliness. It is absolutely something that is at a crisis level. It is something that causes and contributes to just huge challenges. So the Surgeon General saying this. So to the listeners, you can be a part of the solution to that. If you're not a trained clinician, doesn't matter. Just if you see somebody that's isolated, alone, struggling, just be a support to them. Walk alongside them.
Say hi.
Yeah, anything. You know what? And those things can go a long, long ways. I guarantee it.
Thank you, Jeff. You heard it here, everybody. I told you this is going to be a good one. We'll see you next week, and thanks again for joining us.
Thanks for having me.